Uh, Thank you so much, Dr. Shilpa, for having me as a part of this IC. Again, we've been research partners in the development of Visuoprime, which is a made in India device and product for the world. I would like to acknowledge Aditya Goel, who's a senior colleague of ours from the Shankara College of Optometry, and Madan, who's the founder of Neuropy Solutions. I'm here to share how we've been using Visuoprime to actually expand the boundaries of amblyopia therapy. As Dr. Shilpa mentioned, amblyopia we all know has been defined largely as a decrease in the visual acuity in one eye due to an abnormal binocular interaction in one or both the eyes. And we know that it's a result of pattern vision deprivation during a very sensitive period, and in appropriate cases it is reversible. So all this is knowledge that we know of, and like Dr. Shilpa mentioned, occlusion remains the primary therapy that we do. When we went back and looked at some of our children who we had advised occlusion, we found that almost one third were not really compliant. You told them 6 hours, they would do 4 hours. You tell them 4 hours, they'll probably do 1 hour 3 days a week. That became a problem. The second we found was a number of them did not even know that they had to wear glasses. They assumed that they could either wear a patch or a glass, and they thought that both of that could actually help them improve their vision. More interestingly, we found parents, you'll see that one circle there. There's one child that used to be patched whenever they would sleep, because that was the time that the child would actually allow the patch to be put. So they did 6 hours of patching. Parents said we actually do 8 hours, but that is when the child is sleeping. So we looked at all of this, then we started looking at what was available in the market, and we realized that most devices or most solution at that point in time worked on the principle of the dichoptic stimulation. So in dichoptics, essentially what happens is that the images are superimposed when they are seen together, but however the dominant eye gets an image with a slightly lesser contrast, and this kind of helps it. I'll just show you some animations to kind of highlight how this very simply works. So you can look at it. The blue is supposed, imagine that to be the amblyopic eye. So over a period of time, gradually the contrast improves and it works. So our first initiation with computer-based therapy was with a system called the HTS. This was a US-based solution where you actually had a toggle that had to be put into the system to power it up, and it had multiple games that could be worked. It worked phenomenally well. Again, I'm talking of an era about 13-14 years back where pen drives used to be very expensive, and every month this toggle would disappear because somebody thought it was a pen drive and they would take it home. So we then had to ask them to courier an alternate pen drive all the way from the US. Over a period of time, of course, the company refused to supply because they thought we were pirating their software because the sheer number of toggles we were asking. That kind of forced us to say that can we build our own solution here. So we reached out to our partners and we built this system. Essentially what this does is it blends in diagnostics, it has binocular therapy, as well as it also looks at perception based therapies. It's the entire gamut that it works on, right from accommodation, monocular function, monocular cues, and binocular vision. It looks at stereopsis, anti-separation, and you can even do a random dot stereogram based on the system. Essentially this works both in premise as well as a cloud based model. The patient is always under the direct supervision of the doctor or the therapist, and you have control in terms of choosing which module you want to trigger. And again, there's a lot of work that we've done working with children with autism spectrum that we've incorporated as a part of this. This also gives us, because it's sitting on a cloud, the flexibility of doing a part of it even out of home. So the patient can access this therapy remotely. The doctor can prescribe, monitor, manage therapy anywhere. And we've also looked at making it kind of a mobile friendly. So that's a work in progress that we are currently working on. When I say it's used across the world, it literally is. We have patients who are logging into the system from pretty much all across the world into using the system. So these are some videos that shows the kind of various activities that the patient actually does. So they can wear a polarized glass, or sometimes they can wear a red and blue glass when they're doing it as home therapy at home. But based on the dichoptics, it kind of splits it out and very simply does it. Monocular fixation in a binocular field is probably the cornerstone of most therapy that is done. So here largely it works on improving the sensory status. So this again is a short set of videos that shows what is happening here. So here again you see him trying to pick images. So it's like a gamified thing. It's not particularly intelligent, but it has enough variety to keep both the children as well as adults kind of interested, so they don't get bored very quickly. So you can keep playing around with the size, the speed, or you can vary the games also. And currently we're working on seeing that how can all the games be improved even in terms of how it works. Then we also use some amount of TV trainers. This again works on in terms of anti-suppression. Uh, so again, you look at the image with one eye being occluded with an image and through the filter, so automatically the person sees better. We've done stereopsis both for distance as well as for near. Again, here you can see this person, she's just clicking on the images that she sees, and gradually over a period of time, the more evolved stereopsis can be measured. This again helps us in kind of understanding what the possible suppression scotoma is and gives us a surrogate of what the possible visual acuity is. So the first application we did and the first publication we had as a part of this was looking at adult anisometropes. So typically when we talk of amblyopia therapy, we say sensitive period 8 years, 9 years, beyond which you can't use. But because it was a new solution, our ethics committee refused to give us approval to try it out on children first. So we first said, can we try it out in adults? And we did try it, and we found it to work very, very well. So we found visual acuity improvement even in those who were not completely compliant with the entire therapy regimen that was there. We saw an improvement in contrast that happened very quickly. We saw a gain in stereopsis in about 7 patients, but again, in about 1/4 of them, we are not very clear how that mechanism works. We would love to believe that it is completely because of the solution that we built, but again, that is something that we don't know. Then COVID hit. In COVID, again, when we went back and looked at our patients walking in, we found a large number of them not coming into clinic. Almost 70% of patients and parents had actually discontinued therapy. That then got us thinking, saying, since it's sitting on, and that was the era where we were doing everything on Zoom. So we said, if everything can happen on Zoom, why can't evaluation and therapy also happen on Zoom? So here you can see that on a phone call it is being done. So earlier we used to give them access to our system using AnyDesk. Now we've stopped it because of data issues and privacy issues. But this is an example of how they use an AnyDesk. The patient is logged in, our optometrist is with talking to them on the phone, actually seeing what they're doing, and you can pretty much get them to do whatever test that you were doing in clinic with them logged in from their house. Advantage here being the optometrist is actually seeing what the patient is doing, and you can very easily then modify what tests you want to do or play around with that part also. We did use this for therapy. This was done as a postgraduate research by one of our optometry students, where we looked at around 400 patients that were done. We found improvement in stereo acuity equivalent to those coming in clinic as well as those who were accessing it remote. We saw improvements in visual acuity, even visual acuity measurements were the same. Horizontal, vertical foria measurements, both in clinic as well as using the system remotely, were the same. We were able to get a reasonably good size measure of the suppression scotoma, as I mentioned, and that helped us look at what possible visual acuity they had. When we looked at both in-office as well as remote or supervised vision therapy, like we like to call it, we found both of them to be actually quite similar in terms of the outcomes. The advantage is that the patient has the convenience of doing it at the time that they want. They can do it without any time constraint. Disadvantage is they have to be motivated enough to do it. So when you have a solution and you know that you can access it anytime, there is a tendency that you may not prioritize it or you may not have the discipline of doing it. And there is a possibility of discontinuation. Again, all therapy can be done only using the software. It does not give you the luxury of being in office where again you have multiple therapy. You can do certain manual tests to break the monotony. You can work on certain aspects using flippers, prisms, multiple other, you can use the entire Bernal equipment set that is available. And here the subject expert is hovering around the child's shoulder, literally seeing what they're doing to make sure that they're not guessing or not playing a game where they don't care. So again, children being children will treat it like a video game. They're okay if they miss a few things, but here you want them to concentrate on it. The disadvantage of the in-office therapy is there are expenses, both direct and indirect. The parents also have to take off from work to accompany the child into clinic. So which is where this kind of expanding the borders using supervised remote therapy does work, where you can use, like I said, a platform like Zoom to enable access. So therapy again is given under supervision of an expert. There is no time constraint. Connectivity continues to be a challenge. Those of us at the conference have seen how connectivity can be patchy. So if you're depending only on an internet-based solution, you may have a challenge in terms of how it is. And again, you have the disadvantage of only software based therapy. So this again is an example of what we've now started doing. So this again, you can see him on a Zoom. He's logged in. He sees the screen. He sees the patient on the other side, and he's kind of telling him. Unfortunately, the audio is not playing, but in that you will see him saying, "Please come forward. Don't go too much back." And again, a multitude of activities can be done. He's not only looking at the response, but he's also looking at the distance that the patient has from the screen in terms of what they're doing. So that kind of works as a wonderful via media in terms of what we are doing. Uh, is this instruction course even relevant? Is what we are talking even relevant? We did a small study where we reached out to among eye care practitioners in Karnataka, and they felt almost 55% of them felt that it was very, very feasible. And when we looked at awareness and attitude among them, almost 35% of patients we found, both among patients as well as caregivers, the feedback we got was more than 1/3 of them are compliant to conventional treatment. So there is a challenge there. 2/3 are not complying. 54% of them felt digital based treatment could work. 70% of them did prescribe some form of computer based video games that they thought would help the child. So we feel that this is something that has a great way forward. When you occlude a child, all you're doing is you're trying to improve their monocular visual acuity as a primary outcome. If you're happy with that, then yes, occlusion is more than enough. If you want to work on contrast, if you want to work on vernier acuity, the spatial correlation, perceptual attributes, contours, stereo acuity, and if you believe that amblyopia is a binocular condition that needs to be solved, then definitely you need to look at some form of binocular therapy. What we've attempted to do is build a solution that is adheres to the tenets of how exponential technology should be used in healthcare. We've tried to make it value based, where there is immense value to the patient as well as to the parent. The solution is tailored to the needs of each individual patient, and it allows immense customization both in terms of the clinical decision making we do as well as the practice that we entail. And this is a solution that is available on demand, whichever part of the world you may be. Once again, I would like to thank Dr. Shilpa for inviting me to be a part of this IC.
Thank you, sir.
If anybody has any questions, you can take it forward because he has another presentation.
What's the cost of this?
Ma'am, we are not dealing with it commercially, so honestly, I have no idea. We were just the research partners. So Neuropy is the company that deals with it. You could reach out to them. So, but it's not Neuropy, Neurapy. So you could reach out to Madan from Neuropy. He would be able to reach out. But if I'm not mistaken, it hovers in the lower lakhs. About 3 to 4 lakhs is what I guess it is. Again, I'm not very sure.
And how much it costs to the patient?
Ma'am, it depends on what you want to give it to them for. So it's a SaaS model. So you can decide whether you want to charge them per session, you want to charge them for 120 runs. So that flexibility is there with you. So it's up to you how you want to drive it.
Is it kind of a login, like you can, for every patient there is a login? And
Yes,
you
ma'am.
can do-
So that.
can this be done on a mobile device or it's only with the desktop?
So currently we're working on a mobile device. So there are certain challenges with the mobile device because of the screen size. When you use a laptop or the desktop, you can actually trigger the camera on the laptop or the desktop and use that for multiple other assessments. So as a part of the solution, there also is a patent on doing a Brock string. Using this particular solution. So there you need the camera to know what the distance is, and that kind of helps you do that. But yes, we do understand that not everybody can afford a laptop, and that was becoming a barrier. So we are in the process of validating what we built for a mobile based platform.
Is there a tracking system, like how long they have done? Because you
All of that gets tracked. What exercises they've done, how long they've done, how many times they've done, whether there's a dropout, if the session. So the challenge with most of the overseas solutions is that once you lose the internet connection, that session is deemed to be completed. But here, because we know India and we built it for India, there is a lot more flexibility that is available there.
how often do you call these kids or the people, like once the thing from the?
But typically this lasts for about 120 runs, so we usually tell them to do this for about 2 to 3 months and then come back in. By then we see quite a good improvement, and then you use the balance sessions that are there in form of a maintenance therapy.
Every time they have to log in, so you have to log in from our side and.
No. So if they're doing the home therapy, they have the username login. They directly go into cloud into their account. As a practitioner, your dashboard will show what has been done.
Okay, it's not you are asking, inviting them to a Zoom and all.
So we've started doing that now for a set of patients who say that, look, I don't want to buy a software, or I don't know how I can't understand it, or both parents are working. That's extremely common now. So they say we don't want to leave our child alone on the internet. So there we kind of offer this option of a monitor therapy, where through Zoom they log into our system, access our system. So we treat it like an in-office computer-based session. That's it. Right.
Thank you, sir.
Apologies. I have another talk that's clashing. Sorry about that.
And thank you, sir, for